All of us in this audience will agree that the most important global goal as treatment of lupus nephritis is very long-term preservation of renal function. What do I mean by very long-term preservation? That is not 5 years, neither 10 years, but likely 20 or 30 years, since we all know that lupus nephritis starts in the third or the fourth decade of life. We should avoid side effects, and this will all contribute to improvement of quality of life and clearly survival. How can this goal be achieved? No other way than to achieve complete remission. And complete remission can be defined as a urinary protein creatinine ratio below 0.5 milligram per milligram, that is by and large 500 milligram proteinuria per day, and a normal or a near normal glomerular filtration rate within 10% of normal if previously abnormal at baseline. When should that goal be achieved? Well, data from the Lupus nephritis trial and the maintained nephritis trials clearly show that as far as proteinuria is concerned, most of the job is done after 6 months of therapy. Yet some patients with more severe disease at baseline may need some additional 6 months to see a real effect. So the answer to that question is between 6 and 12 months of therapy. Which drug should we choose? The puzzle is becoming more and more complicated. If we were smart enough, we would adopt a patient-tailored therapy approach, but we are not, and so we have to proceed by a trial and error approach. I'm not going into the history details of the saga of the lupus nephritis therapy, but I would like to highlight with you some milestones and to draw some conclusions for the clinicians at the bedside. The first milestone clearly was the discovery of glucocorticoids. Not a single drug has improved survival of lupus patients as much as steroids. It is not very fashionable these days to say that, but this is the truth. Steroids have increased a survival rate from 50% at 3 years in the early 50s to more than 92% at 10 years in 2010, including in lupus nephritis patients. But of course, it was the first success story. It was also the first nightmare for patients and nightmare for their physician. And this is because, as already said several times in this meeting, steroids are the main cause of damage as measured by the SLIC ACR damage index. In the Toronto inception cohort, the damage index jumped from 0.33 at baseline to 1.9 after 15 years of follow-up, and that was clearly, in half of the cases, glucocorticoid related. In the Baltimore incident cases, accrual of organ damage did correlate with a mean prednisolone dose, and the cutoff dose was somewhere above 6 milligrams of pred per day. And in the London inception cohort, damage accrual was found to be associated with increased mortality, 1.32 times more likely to die if you have one more point in the damage index. And this is why I teach my students, when you decide a dose of steroids divided by 2, it still works. But I'm not as brave enough as Liz Lightstone, who makes this very bold statement, no steroids, please. She will discuss that. But please note that this has yet to be proven in a controlled trial. The second milestone, clearly, was the unloved NIH regime. I'm sure that some people still in the audience, quite rightly, uses the high-dose IV cyclophosphamide regime for induction, that is every month for 6 months. But I guess none of us uses anymore the maintenance therapy with the high-dose NIH regime, which was a quarterly basis regime for 2 or 3 years because, of course, premature gonadal failure. I dare to say that the introduction of the Lupus regime was a challenging event. We use 500 milligram fixed dose of cyclophosphamide, as you know, 6 times apart every fortnight. It's a very patient-friendly and user-friendly drip infusion, and we start azathioprine at week 12. Please note that in the Lupus regime, the steroid regime was much lower than in other trials by that time, with only 3 pulses of methylprednisolone and 0.5 milligram per kg of oral steroids, tapered down quite promptly. And as I keep telling, to summarize 10 years of my life in one single slide, this is the data for the end-stage renal disease rate, and you see that patients given the low dose, the Lupus regime, did not did as well, I would say, as patients given the high-dose NIH-like regime. I'm always puzzled with this question, but is the Eurolupus regime efficacious in severe patients? Eurolupus, that is good for Caucasians, mild disease, but not good for severe patients and for non-Caucasians. Well, the answer is, it is efficacious in severe lupus nephritis. Out of the 90 patients randomized in the ELNT, 42% of them had poor baseline prognostic factors, defined as a serum creatinine, bottom line here, superior or equal to 1.3 milligram per deciliter, or a proteinuria, which was in nephrotic range. And you see that about 10 years later, if you look to the percentage of patients with a serum creatinine superior to 1.4, or those who died, who end up in end-stage renal disease, you can hardly see any difference between patients given the low-dose therapy, the Eurolupus regime, compared to the NIH regime. That is, after 10 years of follow-up, specifically looking for the poor prognostic patients at baseline. The assumption that the Eurolupus regime is adequate for benign lupus nephritis cases only is not supported by data. Clearly, the new star is mycophenolate mofetil. Patient-friendly, does not induce gonadal failure, likely not oncogenic, can be monitored through trough level of MPA. It is the best studied drug in lupus nephritis. I think we can state that MMF and IV cyclophosphamide are really equally efficacious to induce a response in the first 6 months of lupus nephritis. These are data collected by the Toronto group. It's a meta-analysis comparing or pooling 4 randomized controlled trials, comparing MMF and NIH cyclophosphamide. Please note that the Eurolupus cyclophosphamide regime has never been compared to MMF. And what they look for is induction of a response at 6 months. And you see in this forest plot that partial and complete remission were equally frequent in MMF patients and IV cyclophosphamide patients. Quite surprisingly, the two drugs are equally toxic. And that was a surprise. We would have anticipated that MMF use would be associated with less side effects, in particular infectious side effects. And this is not the case, even not for herpes zoster. And this is probably because most of the toxicity of the drugs in the first 6 months of induction therapy is due to steroids instead of the other immunosuppressant. Needless to say, there were more gastrointestinal and transient amenorrhea and alopecia in patients given cyclophosphamide. Please note that the number of deaths in these 4 trials was very similar in patients given cyclophosphamide compared to patients given MMF. The two drugs are equally effective, equally toxic. Then the question comes, is it time to retire IV cyclophosphamide from the lupus nephritis armamentarium? And the opinions differ quite a bit. These are 2 studies and editorials, and I read them with you. The first one in Kidney International by a nephrology Colombian group, stating that MMF should now be considered standard first-line therapy for lupus nephritis. And another paper published very recently by Brad Rovin, it's a study actually, stating that MMF cannot yet be considered the drug of choice for induction therapy of severe lupus nephritis. And this paper is co-signed by Daniel Chan, by Ellen Gisler, people who were very pioneering in the proposal that MMF should be used as standard of care. Why is that for? Is it because MMF is less efficacious than IV cyclophosphamide for histologically severe lupus nephritis? The answer is no. Look to the data, a Chinese group in crescentic glomerulonephritis, very severe cases, 50 cases, and you see that MMF performs even better than cyclophosphamide at 6 months in this very severe crescentic lupus glomerulonephritis. Is MMF less efficacious than IV cyclophosphamide in clinically severe lupus nephritis? Well, this is an analysis by Brad Rovin. He looked for the 23% of patients who, in these 4 trials, had some degree of renal impairment, defined whatever it is. And you can see that the response at 6 months, the complete response rate and the partial response rate between MMF patients compared to IV cyclophosphamide patients were very similar. At month 6, MMF with steroids is as efficacious as IV cyclophosphamide, with steroids in patients with at least some degree of renal impairment. And that is important. I would like to stress that one of the reasons for that may well be that if most of the side effects are related to the steroids in the first 6 months, it may also be that most of the effect in the first 6 months of induction is also related to the steroids, at least in the regime we currently use. Now, the other reason is why we don't shift completely to MMF is MMF as efficacious as induction with cyclophosphamide in the very long term? That is an important question, and we don't have the answer to that question yet. We need some more time. I would just like to introduce a very short note of caution in this respect. Well, actually, two notes of caution. The first one comes from the ARM study. You know that patients were randomized between MMF and IV cyclophosphamide, and if they had achieved a response, they were re-randomized to receive MMF or azathioprine. And somewhat surprisingly, you see that patients who had been induced with cyclophosphamide and maintained with MMF were those patients who had the lower recurrence rate of renal disease. The trial was not designed to prove that, and we should be cautious in interpreting that data. But it introduces a note of caution, interestingly. The other note of caution about the long-term effects of MMF is this paper recently published. It's a retrospective study, again with caveats from Korea, showing after 10 years of follow-up that patients given MMF did less well regarding probability of end-stage renal disease compared to cyclophosphamide. I'm not saying that we should not use MMF. I'm just saying that we need more data on the very long-term consequences of MMF induction. Briefly, for maintenance, I will be very brief on this topic. You know that in the ARM study, mycophenolate mofetil was found superior as far as renal failure was concerned compared to azathioprine. And interestingly, in the other trial, the maintained nephritis trial, which we coordinated in Europe, this difference was not statistically significant. We saw a very faint signal, I would say, 6% difference between MMF patients and azathioprine patients for maintenance, but this clearly was not neither statistically nor clinically significant. Why are ARMS and maintain so different? There are differences in design. We come to that later in the discussion, should you wish so. But please note that the percentage of patients who had a renal flare in the azathioprine group was very similar, exactly the same in the two studies. The difference was the response to MMF. And I'm not sure that this is a causal relationship, but it is amazing that, of course, the ethnicity was quite different. We had mainly a Caucasian population, while it was much more mixed and much less Caucasians in the ARMS. Whether a different ethnicity explains the different results is far from clear. The power of the study was not enough to prove that. And I would like to conclude with 2 or 3 slides, which I called my eminence-based forest plots in lupus nephritis. This is, of course, a little bit evidence-based, but also a bit eminence-based, and I apologize for that. As far as short-term efficacy in lupus nephritis, I think we can say that both drugs are equally effective. Contrary to what we anticipated in the early days, as far as short-term efficacy in severe lupus nephritis is concerned, both drugs are equivalent. As far as long-term efficacy, I would still favor IV cyclophosphamide because we still miss some long-term data, but I'm willing to change my mind as soon as these data become available. Surprisingly, regarding side effects, well, they are equally effective. MMF is not superior, probably because of the steroids, as we already mentioned. Clearly, for the other side effects, that favors MMF, because you don't have, of course, the premature ovarian failure and the gastrointestinal side effects. Cost, well, quite surprisingly, it may well favor MMF, because you have to take into account the injection and the hospitalization for the high-dose cyclophosphamide regime. But, of course, adherence favors IV cyclophosphamide because you're sure that the patient gets the drug, and monitoring favors MMF because you can monitor the titers with the trough levels of MPA. This said, if you use the Eurolupus cyclophosphamide regime, Of course, you will have much less other side effects of the high-dose cyclophosphamide. You don't have amenorrhea, you don't have gastrointestinal disturbance, you don't have alopecia. And of course, the cost of urolupus IV cyclophosphamide is much lower since you don't need to do hyperhydration and to hospitalize the patient. Regarding maintenance, how is my forest plot? Prevention of relapse, well, okay, favors MMF, but again, if you look in Caucasians and the maintained nephritis trial data, they may be comparable. Regarding side effects, no doubt that the drugs are comparable. Oncogenicity probably favors MMF. Azathioprine is probably likely more oncogenic, a little bit. But the major advantage of azathioprine is the possible use in pregnancy, of course, which is not the case, at least in the first trimester with MMF. And the cost favors azathioprine. This said, as a conclusion, what has improved lupus nephritis over time? Targeted therapy, we heard a lot about it. No, not yet. Hopefully, yes, in the future, but not today for the patients we meet at the bedside next Monday when you go back to your clinic. Standard immunosuppression, clearly, we use more friendly regimes, and that really makes a difference for the patient. But the most important point is optimal global care, and that is less steroids, indeed, treatment switch when the patient does not respond, prolonged maintenance immunosuppression, optimal renal protection with Kidoki Kidigo, you have to rehearse to say that in the first time. Prevention of cardiovascular disease, prevention of other comorbidities, very important. Never forget plaquenil, even in patients with lupus nephritis. Unmasking non-compliance to therapy is a very critical issue in these young patients who take so many pills. And you should not forget, never forget, that drugs don't work in patients who do not take them. Thank you very much indeed.
That was great. We can have questions at the microphones.
Hello. Fred, hi. David Eisberg, London. Thank you for a really outstanding talk. The only thing I would ask you to perhaps reconsider in your very beautiful forest plots is the question of oncology and mycophenolate compared to azathioprine, because after all, azathioprine has been around for 40 plus years, mycophenolate maybe 10 or 15, so we really don't know about long-term oncological effects of mycophenolate. And certainly in the SLIC studies which have looked at malignancy, the risks of oncogenic change over time in patients seems pretty small. So that's the only caveat I had. Otherwise, a great talk. Thank you.
Agree, David. My point is that, as you know, in Crohn's disease, for instance, they made some fancy study on lymphocytes of patients treated with azathioprine for years, and they observed some very funny abnormalities, but it may be not reliable for lupus. I agree with you. Thank you.
Liang, and I'm proud to say I'm from Boston. Would you comment on the use of oral Cytoxan instead of IV?
Yeah, I didn't mention that for the sake of time, but as Bevra will probably mention, oral cyclophosphamide is also an accepted therapy of lupus nephritis for induction, provided you give it for only a small period of time, probably by and large 3 months, to avoid the toxicity of oral cyclophosphamide. But your point is well taken. Yes.
Houssiau, Buenos Aires. When in practical terms, when you say MMF, to which dose are you referring to?
Yeah. Well, the doses in the studies, they range from 1.5 grams to 3 grams. So it is not that clear that the dose should be reduced according to ethnicity. It is common practice to do so, and in Afro-Americans, the usual dose is more than, is by and large 3 grams, in Caucasians 2 grams, and 1.5 grams in Asians. That's the way we do it. But there is not very hard data to be sure that we are doing well. We should measure trough level. I think rheumatologists should follow the example of nephrologists in this respect.
Yeah, because I remember that in the Ellen Ginsler trial,
yeah,
regarding MMF, the anticipated daily dose was 3 grams.
That's correct.
And when you look at the results, only 2/3 of the patients were able to maintain or reach 3 grams per day because of toxicity or intolerance.
Yeah. In the ARMS trial, tolerability of MMF at 3 grams a day was very good.
Yeah. Thank you.